Ladies and gentlemen, welcome back. We now have our keynote address on Malaysia's health white paper, Healthcare Reform for Greater Sustainability and Resilience. With that, please join me now in welcoming on stage Tan Sri Dr Subramaniam Sathasivam, the former Minister of Health Malaysia, Senior Leadership Fellow, Harvard School of Public Health 2021, World Health Organization STAG Medev Advisory Group member, and the co-chairman of Health White Paper Advisory Council. Tan Sri, welcome.
His Excellency Dato Sri Setia Dr. Haji Muhammad Hisham bin Haji Jafar, the Minister of Health of Brunei, who is here with us today. Colleagues from the rest of the ASEAN countries, friends, ladies and gentlemen, first I'd like to thank the ASEAN Secretariat and the Brunei Ministry of Health for having invited Malaysia to be part and parcel of today's event. And I'll be talking about the Malaysian healthcare reform and how the challenges which we are facing. Right. Basically, I'll touch very briefly of our healthcare reform, the challenges which face in our system, what we intend to do, and briefly on the digital transformation which is occurring in our country. Before I go into this, while I was sitting there, I got a bit of enlightenment. When I was a visiting fellow in the Harvard School of Public Health towards the end of last year, there was one statement which I gave the students who were under my class, who were attending the master's class, which I told them will be the mantra of health policies forever. Unfortunately, it's not on the slide, so I have to just tell you because I just thought about it. Basically, the statement goes as, the health policy is a final product, is triggered by the rigors of science, tempered by the powers of politics, balanced by the forces of economy, and molded by the values of society. So to get a health policy right, first, you get evidence in science. But that evidence is useless if the politics doesn't receive it and translates it into a policy. And that policy can only be translated, like what the Ministry of Finance said just now, if the economy is right and it falls into the correct ambits of economy. At the end of the day, while we get all that right, we have to keep cognition of the fact that we are in relation to a society. And unless the values of the society is part and parcel of the policy-making process, then you're not going to get right. So I think, to a great extent, our healthcare reform will touch on the fabrics of those values, which are very, very important. So the first title here is Future-Proofing Healthcare Reform. One of the things which I did discuss when I gave the classes in Harvard was, can we sort of ring fence healthcare reform from politics? In Malaysia, we started healthcare reforms from 1985. Many studies, many reforms. But unfortunately, none of them came into total implementation because of the lack of political will, or the political climate was not right. So we thought we got it right this time. So we had a good minister who was very proactive, very progressive. We had the benefit of COVID, which created the awareness. And all of us got together, put our and say, we'll move forward. Again, unfortunately, we had an election, and that particular minister lost. And today, a lot of Malaysians came to talk to me. Their pulse rates are going up as we wait who our next prime minister is. So that decision today is going to affect whether what I'm going to talk to you today is going to become a reality or not a reality. So this is very, very important, because whether we get the politics of healthcare reform right. So that is why we thought by future proofing what we wanted to do when we started this process, because in 2013, we had a big reform called One Care Malaysia, major transformative reform. In fact, it was an attempt to reconstruct through dismantling. But unfortunately, it became a very huge topic of election. We had the election that year. It became a very hot topic during the election. The reform never saw the light of day. Then, 2018, when I was a minister, we also put reforms. Again, I lost in the election. So that reform never saw the light of day. So now, this minister has started a reform process, and now, unfortunately, he also lost. So now to make sure that doesn't happen, there's two things which we wanted to do. One, we wanted to take this health white paper to Parliament and get both sides of the political bloc to agree. So that's what you see in the last line, for bipartisan support. So we felt if both sides of the blocks are in agreement of the white paper, then they will be motivated to implement it immaterial of who comes into power, because it's their product. So that's one attempt to ring fence it. Number two, we wanted to create, through Parliament, a Parliament, Act of Parliament, a Health Reform Commission, which will undertake the implementation of the policies of the health white policy, health white paper, over a period of time, 15 years. So if it's a commission which comes through an act of Parliament, it will have a long life, and this immaterial, because Malaysian politics has become so uncertain that we don't know who will rule. In the last 5 years, we had 3 prime ministers. So we don't know how, to make sure that despite those changes, there will be a process of continuity, we said, okay, we'll set up a health reform commission. So these elements we thought will future-proof health reforms. So the health reforms, to some extent, we can take it away from the forces of politics. You can't take it away 100%, but to some degree, at least it can start going, because Health Reform Commission will be an independent commission. Of course, it's answerable to the minister, but it will still be able to do its work, okay? With that introduction, I'll go on to the next area. So what you see here is very similar to what both the Minister of Singapore has stated, what the Minister of Health or Finance of Brunei state, that we want to shift from managing ill people to preserving a health society. So that is the main thing. And so that is the major shift. And of course, it has to be equitable, person-centric, and have enough money. The Minister of Finance very well alluded just now that there's never enough money. So how to solve that problem? And of course, driven by technology, and our health system will be people-centric, identifying the needs of the people and how we are going to solve it. So these are the 4 pillars of the healthcare reform. The 4 pillars, the first one is transforming healthcare delivery, is basically of health services, primary care, secondary care, and tertiary care. In this, our emphasis is very much like what was said by the Minister of Singapore. The emphasis will be on primary care. Emphasis on primary care, same principle, identifying family health teams, and getting primary care beyond the boundaries of the clinic. That means taking primary care into the community. So a community will be enrolled into the service of primary care. So the health of the entire community will become the responsibility of primary care. So this is one aspect, rather than just dealing with curative aspects within the ambits of the physical elements of a clinic. You go into the clinic, into the community. So primary care will be important, and that will be the bastion of health services. Secondary care will be used for very acute cases with an intention to decant such people back into primary care or into the community, so that there will be lesser of need to actually invest in the need of hospitals. And the other thing which we want to do is, Malaysia, we got a dichotomous health service. I think it's there in Singapore and many other parts of the world. We got a private health service and a public health service. And the Malaysian private and public is so dichotomous, and they don't read each other. It's not integrated. And because of that, there's a lot of resources which are not well utilized in the private sector, overused in the public sector. So one of the aspects of this health policy is how we can bridge this. How the government be able to optimize usage of the facilities in the private sector at all levels, primary, secondary, and tertiary care. So that will be one of the challenges, how we are going to increase effective private-public partnership. Again, this became a reality, a useful reality, because of COVID. In COVID, the government used the public sector extensively. And that experience allowed us to extend beyond and said that this can be used for a long-term purpose. The next one is, of course, the emphasis. The pillar 2 is on prevention and promotion of health. Here is looking at health as a whole of government approach, whole of beyond not only the responsibility of the Ministry of Health, and how to bring all those forces together to ensure that we can maintain people healthy and we can create a health ecosystem so people can live a healthy life. So in this, the social determinants of health, which are so important in determining whether people are sick or not, will be given importance so that we actually deal with the social determinants very deeply. So that's the second pillar. The third pillar is the one of health financing. Malaysia doesn't spend a lot on health finance. We spend about 4.4% of our GDP in total. Total means both private and public. And our public sector only spends about 2.3% in the thing. So we have said very categorically in the health white paper, government must spend 5% of GDP. The public spending must be 5% of GDP. We give a period of time for the government to achieve it, from the 2.3 or 2.5% of GDP, which is being spent now, to more. So that is the first aspect of health financing. We didn't go into the ideas of getting health financing to social health insurance or whatever, and the other kind of payment induced, because those are the most politically explosive things. So Malaysians have got used to the idea that public health service will be free, and they need not pay for anything. Now when we are going to introduce the idea we have to start paying, that is going to be, you have to prepare society for that. So, and we have to do that in small stages, because we have seen in many countries in the world where health financing has been a very big topic in politics. I know colleagues of mine were ministers of health in Taiwan. A couple of them lost their jobs because of the fact of this health financing problem. So it is a very, very emotive thing, has to be handled very thing. So what we have started is a thing which is doable. That is, the government has to increase the spending which it does, so that will be our first start. And the next start is see how we can actually get the people to pay. Not that Malaysians are not paying, they're paying into the private sector. But the benefit of that system is people can make choices. The rich can choose to go to the private sector and get whatever they want to do, while the poor can fall back on the public sector and get the treatment, more or less the same standards. Maybe waiting time might be longer, but you will get the same thing done. So because of this choice, although out-of-pocket payment in Malaysia is about 35% of total health expenditures, which is very high, but we don't have financial health catastrophe because of that, because people make their own choices. Those who can't afford go into the public system. Those who afford go into the private system. So they don't go into financial catastrophe, except for some who make wrong decisions. But by and large, most people make the correct decisions. That's the third one. And the fourth pillar deals with the Ministry of Health itself. The Ministry of Health in Malaysia is a regulatory authority, is a service provider at all levels. And now there is a big question whether the ministry should function in the same role. Should it also be the regulator? Should it also be the provider? Or it should diverse these responsibilities in a different way. So we are challenging the entire governance of the ministry. So the health reform takes many aspects, from how to improve the service delivery by emphasizing on primary care, maintaining a healthy society by ensuring that there is great emphasis on prevention and promotion. And third thing, work towards more sustainable financing. And fourth thing, looking at the governance of the Ministry of Health itself as to whether it could be restructured. So very briefly on our digital process, next. So these are what we intend to achieve. Mainly, I will talk about 2, integrated health service delivery. Now, our health service delivery, as far as technology is concerned, is very disintegrated. We have health systems which only work at hospital levels and which are not interconnected with the entire system. And different hospitals use different systems, making it more complex. And the challenge is how to integrate all of them to become one. And this is the eventual interoperable ecosystem which we envision to get, which is an integrated Malaysian health involving public, private, every aspect of it integrated into a common system. The first challenge, I think a lot of technocrats are here, how to integrate these systems. So they are integrate these different systems so they can read each other, and the information from one system can be transmitted to another system. So that is our challenge. And for that, we have gone through a process from 2009 to 2015 to now. We have got a National Electronic Medical Record Initiative using a platform called the Health Information Exchange Platform, and trying to integrate a pilot project is going on in one state in Malaysia, involving all the hospitals and all the clinics, trying to integrate the systems in those areas to see how this is working. And to assist that, we are using Health Information Exchange Portal which we have created, which is based on this fast healthcare interoperability resource, which I'm told is a tool, a platform which allows different systems to come out with common codes which can be read by all other systems, which means immaterial of which system you use, using this platform, we will be able to integrate them so the message can go from one system to the other. So using this system, the Malaysian Health Information Exchange is now trying to integrate all the health systems which we have, and this is the pilot project we're doing. Once we do, and that is successful, then that particular thing will be expanded so that we can integrate all the other systems. First within the public sector, then with the private sector. Of course, when we do that, then we need to create the legislative and other support systems, like what was well described by the Minister of Health of Singapore just now, to need to support this, whether doctors will do it, and all the other challenges which we'll have. In this system, we got now 3 portals which will collect information, which can allow the transmission of information. One is the provider portal, that is the health provider. The number 2 is the person's portal, and number 3 is the management portals. So it is possible for information of that nature to be transferred into the Health Information Exchange, so this can be read by anybody, anywhere, once that integration occurs. The other health digital initiative which we did from 2017 is what the Malaysian health data warehouse, where a lot of health-based information is brought into a central warehouse, and this information comes from private hospitals, from public hospitals, clinics, things pertaining to number of admissions, number of discharges, number of diseases. So this and goes into a common data warehouse, and the information which we get, for example, on admission rates, discharge rates, disease-specific admission and discharge rates, registries like cancer registry and other forms of registry, all are generated through this data warehouse. The information which we get from this data warehouse is also shared with other agencies. For example, our Jabatan Pendaftaran Negara, there's National Registry, Department of Registration. All births which happen in Malaysia go through our data warehouse, and that goes into our national registry system to inform the National Registration Department of all the births. So this is not only useful to the Ministry of Health, but the data warehouse, the information which collects, is also shared with various agencies of the government for doing that, and also for research purposes, because the huge amount of information which this data house allows people who are doing research to utilize the information to do more research. Next slide. One aspect in which this data house its usefulness was during the COVID epidemic, where an inbuilt geospatial analysis, which has been built within the data warehouse system, was utilized to actually locate COVID cases geographically. That means by doing this, every case which is notified goes into this geospatial system. From this, the Ministry of Health used to actually announce their clusters. These clusters were determined from here, and from these clusters, as the number of cases become low, they say this cluster is already cleared off and a new cluster is come. So this location of cases in groups was facilitated because of the availability of this technology, where every particular case actually goes into the data warehouse, and that is linked to this geospatial system, and that information actually helps us in planning. So that has been a useful tool which was utilized during the COVID pandemic. Next slide, please. The other tool which we used was an app, like what the Minister of Brunei was saying, was this app which we used during COVID. We call it My Sejahtera. Every Malaysian had this app. It served tremendous purpose in contact tracing, in notifying people of their contact with cases, and people used it to scan to enter into premises. It was also a source of their vaccination. I mean, they can apply for vaccination. We'll tell them which center to go, what time to go. And once they're vaccinated, we'll tell them you're done, and then maintains the vaccination record. So it has tremendous usefulness during the COVID. Next slide, please. So this is the amount of benefit which we got through this My Sejahtera. As far as you see from the bottom, you see contact tracing, nearly about 14 billion total check-ins into the system. Care of patients for COVID through the system itself. The system monitors them. They every day put in their records as how they are feeling, whether they have fever, whether they have headache, and that was used to monitor in case management. And now it is also part, and it maintained the COVID immunization program, and it gave the COVID immunization certificate, which was within there. And then every traveler who came into Malaysia downloaded the app, and they had to put some data into it to enable them to come to Malaysia. And now, beyond that, it has also become part and parcel of a national immunization program, and has been used for health screening. Next slide, please. So the application we started, I think the same experience in Singapore, same reflection in Brunei. We all used the opportunity of COVID to develop a technology and app. Now it's going beyond COVID. Likewise, in Malaysia too, it has gone beyond COVID. We just started during the pandemic. Then after that, well, we are going into endemicity. It used to monitor travelers coming in and through. And now it is using the national immunization program is there. A health screening is being done, appointment systems, and eventually the patients' health records, we hope, will be part and parcel of the system. People can apply for appointments. They can do the organ pledges. This is very important because very often, although people have pledged their organs, but after they've died, sometimes nobody knows whether they've pledged it or not. And when you ask the relatives don't want to make decisions on behalf of the deceased. And that's a very emotive thing. So once we have this, and there is actually an evidence that the person has actually pledged, it will be easier for us to actually harvest organs. So that also is part and parcel of it. And eventually, we hope it will become part and parcel of our electronic health record. So this is an example of how a technology which came during COVID actually is becoming more useful in the post-COVID period. Next slide, please. Other than that, we also develop other tools to assist us in the management. One is the vaccine management. We had a very massive vaccine management program, and we vaccinated people in historic speed, I think, for a country like Malaysia. And that was assisted by a tool from end to end, from supply to appointments to the centers and the entire management of the whole vaccine management system from the beginning until the end. Likewise, there was another tool which was also developed in assisting health departments and both at the state and district levels in managing their COVID data and management, which we call e-COVID, which integrated information from labs, the number of cases, and they were able to generate data. So these were the tools which came in the wake of COVID, so that which were useful, and which, when we look back, whether we could have managed COVID without these tools in the conventional manner is actually unthinkable. Unthinkable that we could have actually managed COVID in a conventional manner. With, looking back how we managed things about 10 years ago, all through phones and paper and protocols and forms to be filled up, something would have been a real nightmare. So the advent of technology has actually facilitated us in the management of these things in a much, much more better and effective manner. Next. Next slide, please. Right. So in digital health, when we want to implement this or this, and our biggest challenge now is getting electronic health records across the country. Of course, there are many challenges. One is, of course, the policies and the governance of it, particularly pertaining to data and the security of such data and the rights of people. We need to manage it. Number two is to ensure that we got the adequate infrastructure, particularly in a country like Malaysia, which is so widespread. We got urban, rural, and very, very rural, particularly in neighboring Sarawak and Sabah. We have clinics to which you have to approach the clinic. You have to go by four-wheelers on mud tracks, and after that, probably you have to go by boat through a river to reach a very hinterland. To ensure that those kind of areas are going to be connected, you have to ensure that they've got connectivity. So that's another challenge, to ensure there's connectivity is there, the infrastructure is available for them to use this technology, and to have systems which will actually enable this. And of course, like what the Minister of Finance of Brunei said, we have to talk through this financing of this. Of course, initially the capex is going to be high, but is the conversation which is going to get that funding to show that this investment is going to come back in many folds after many years. So unless that convocation, that economics is got right, this policy will never become a reality. So it's important to get that conversation right, that we need to predict, to extrapolate to what an extent this investment and the benefit of it is going to come in the long term. So that's very important. And people. This is very, very important. Even in very advanced countries, there have been resistance from segments of the medical fraternity itself to actually utilize technology. This is because of various reasons, because of generations which are probably not literate in current technology, or apprehensive or aversive to use it. We have to go through this process. So you need to prepare people so that they are ready to use it and they are willing to use it. If not, means this entire process will be wasted if the people who are supposed to use it don't use it properly. So it's important to actually understand that, not neglect it, recognize that there are pockets of people who believe, who might not be willing to come forward for various reasons. Some might think that it's slowing my process. Some might think it's reducing the productivity. Some might just think that I can't do this, and how are you going to manage this? These are real problems and we face in many other countries in the world who actually initiated these processes, and these challenges have to be taken into consideration in trying to move forward. So whilst we manage all these challenges, while these challenges are there, we have to take into consideration the fact that all this is worthwhile because the future relies on our ability to harness these technologies for the better of healthcare. And it's going to totally transform healthcare. And it's important for governments to realize this and to invest in it, and for getting everybody into it. The most important thing is getting everybody into it. For example, when we want to get this into the private sector, particularly the primary care doctors in the private sector, most of them are single practitioners. That we got 6,000 over such people in such clinics in our country. And all of them have got different systems. Some of them don't even have computers in the offices. So how to actually get them on board? I think that is a very important challenge. And rejecting it, neglecting it, or feeling that that doesn't exist, that would be wrong. Is to recognize that it exists and then try to have the conversation where they can become part and parcel of this pool. And that is going to be one of the predeterminant factors which is going to ensure the success of this whole process. Next. So to come to an end, as we move forward, the post-pandemic transformation requires transformation, but we need comprehensive planning. That's what we are attempting to do now, because COVID gave us an opportunity. I think for all countries, COVID gave it brought awareness of public health from being hidden to center stage. And it's up to Ministry of Health to actually exploit this advantage to inform governments of this importance. This is very, very important. So COVID is, like, as is always said, crisis provides opportunities. And COVID as a crisis has provided a tremendous opportunity for health transformation all over the world, particularly in ASEAN countries. So we utilize that. And all I have stated about the adapting health in all policies is very, very important. We even considering in our health white paper requiring the government, whenever any policy is passed, it's important the health cohesion of that policy becomes a part and parcel of the process of approving such policies. This is important. Even a development project, what is its impact on health and how is it going to impact health? And that has to be considered before it's passed. So if that kind of concept becomes part and parcel of the government's policy-making process, and we consider health is not only the domain of the Ministry of Health, but it's the responsibility of the Ministry of Education, Ministry of Agriculture, Ministry of Environment, Ministry of Housing, Ministry of Finance, and everybody, and bring all of them together to actually understand, incorporate health into their ministries, and assist in that process, then this vision of health in all policies will be achieved, and that will solve a lot of problems. Imagine a society from small has been educated to be health literate. How easy it will be able to for us to actually give informations later on. Imagine cities which are so well planned, so it is allowing us to walk and exercise and be physically fit. All these are going to be beneficial. So it's very, very important that this health in all policies is important. And the new technology has given us the opportunity to make decisions based on evidence. Before, we made decisions on perception. Sometimes we make decisions on political benefits. But now we have the advantage of making decisions based on evidence and hard evidence. And it's easy to get evidence. It was very difficult to get such evidence before. So now once you're able to, the whole decision-making process within the health environment can now be evidence-based. That means that the evidence base is important because it also determines on resource allocation. Where you're going to allocate resources. Are you going to allocate resources for areas which are already crowded? Or are you going to allocate resources in which your evidence shows that investing there is going to give you a future return, which is manifold? So these are important things which we have. We are tools which we have, which is going to assist us in this process. So in the future, this is what it's going to help us. Yeah, I'm done. So how we utilize this. So that means, to sum it up, one, we have to recognize that shifting society from a state of illness to health is very, very important. We need to transform government to ensure that health is not the responsibility of the Ministry of Health alone, but is resolved to the entire government. Number three, we need to make our decision-making processes based on evidence, not on perceptions or likes and dislikes of individual leaders. And with that, we have to consider that how we can invest into the current to protect the future. If we do that, I think we will have a good health system. With that, I thank you very much. And I'm here to willing to listen to all the others as they give their views over the next couple of days. Thank you very much.